Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
2 abstracts made it to New England Journal this year from ASCO. World Lung is coming up in less than a month, and the most important study, FLAURA2, which will impact the standard of care globally, especially in Southern California, EGFR mutated lung cancer patients. We'll talk a little bit about that. And the ESMO, there's a deluge of abstracts that could make the plenary sessions and also the lung session. So if you want to go to Madrid, this is a good place to learn in terms of the abstract. So ADAURA overall survival, we all know about ADAURA PFS already. KEYNOTE-671 is something that very interesting, changed my mind a little bit. So this is perioperative pembro for early stage, locally advanced early stage. Very simple design. It's essentially neoadjuvant chemo IO followed by adjuvant IO versus neoadjuvant chemo, and then nothing else. So it's placebo. So we know the result's going to be positive because you get neoadjuvant and adjuvant IO versus nothing, and we already have IO approved. So always the question is which is better, neoadjuvant chemo IO versus adjuvant IO, or you do both? And if you're going to give adjuvant IO, whether you need neoadjuvant chemo IO. So this actually addresses very important questions. If you look at, if you are fortunate enough to get a PR or a PCR with chemotherapy and you don't get any IO, you actually do better than if you don't get a PCR with neoadjuvant chemo IO or just and plus adjuvant IO. So getting a PCR status or a good, now we are borrowing from the hematology, which is major partial response, MPR. So it gets very confusing. So upfront treatment is more important, even if you don't get adjuvant IO. So that's, I think, practice changing, and it got into New England Journal of Medicine. And about a month after ASCO, this randomized phase 2 trial also got into New England Journal of Medicine. I think partially on the coattail of the KEYNOTE-671. This is from the Spanish group, one of the major cooperative group in the world. I like to use their formal name, Grupo Español Cáncer de Pulmón. So they are very strong. Even though this is a randomized phase 2 trial, they prove a point. Everybody in this got adjuvant nivolumab for 6 months. So the difference is neoadjuvant chemo IO versus neoadjuvant chemo. And because everybody got 6 months of adjuvant IO, the difference is neoadjuvant chemo versus neoadjuvant IO. And you can see that giving neoadjuvant chemo IO has improvement in overall survival. And so even though this is a randomized phase 2 study, it got into the New England Journal, and that's why the previous trial, while it's still in the New England Journal, does not have a page number at this point, because New England can get you a page number in 2 days. Unlike other journals like JCO, it takes you a year before you get a page number. So that's proved the point that neoadjuvant chemo IO is now becoming more important. And the adjuvant IO, we may use it, but we may or may not be as important as getting a pathologic response or major partial response, which is like 30 years ago as a fellow, and then we learn about breast cancer. That's the NSABP B28 trial, if you guys still remember. Adjuvant ADAURA, we all know we expected the overall survival to be positive, and it was indeed. It was a plenary session. I think it was right after the rectal cancer session that Dr. Zhao, I couldn't find a seat at the rectal cancer session, but after the presentation, I saw a corner seat. I sat there and listened to Roy Herbst, and then I have to go to some other meeting. But it was a simultaneous New England Journal I knew it ahead of time. I shouldn't say that, but so it wasn't like I need to sit through the plenary session. But it is positive. It's mostly positive for stage 3. We will have more and more secondary papers coming out of that, but overall it is positive. And also, if you just compare the 2 blue lines, whether it is you need the adjuvant chemo or not, it's not as critical. It's most important to get osimertinib for 3 years. And always the question is, what if you give it 5 years and all that? We will entertain questions a little bit. But the most important study that is going to come up, it will be presented in September 11 in Singapore. So it will be September 10th in the US. Pretty straightforward. You build on osimertinib. What else can you add? You add chemo. So osimertinib plus or minus chemo. Very straightforward. We already know this is a positive trial. AstraZeneca has a press release. How positive it is, we don't know. So these are my questions. What are the relative and absolute benefit? I think we use a lot of chemo plus TKI in the US, in Asia. That's almost a taboo. So we'll see how widely this is adopted. Subgroup analysis is important. We know L858R subgroup is less favorable in terms of response and overall survival, and also the CNS metastases with or without CNS metastases. How tolerable is osimertinib plus chemotherapy? We don't know, but there will be a lot of subgroup analysis, and we anticipate this should come out, in the England Journal too. It's a high-profile paper, a practice-changing globally. So another competing trial against FLAURA2 is Mariposa, which is lazertinib, which is a third-generation EGFR, very similar to osimertinib. It's developed from Korea. Well, it's developed in Boston, that licensed to a Korean company, and now J&J has owned the rights outside Korea and outside China. So it's lazertinib plus amivantamab, randomized to osimertinib. The FDA requires the company to do a lazertinib trial. And the red blocks they're really placebo controlled, so you really don't know what you're getting. You're getting a pill plus placebo. And because the way is 2-to-1 randomization, you actually get more patients on a control arm than the investigational arm. So Jason may have something to say. So it's a 1,000 patients trial. So 600 patients will get TKI, 400 patients will get lazertinib plus amivantamab. That you know it, you are getting it because you're taking a pill. We are getting an infusion. We don't know the results. So it is a stealth or whatever abstract at ESMO. They already carve out a space for a plenary session in case it's positive. We think it is positive, but not as positive as FLAURA2. We also think it could be negative, but this is something within the next 2 months we will know, Mariposa versus FLAURA2. Of course, every one of us will say, well, it's lazertinib or osimertinib the same, because even though this is blinded, they know. So there will be subgroup analysis, and people will ask, because we are used to osimertinib, lazertinib is not approved in the US. We participate in some of their trials, so it's relatively tolerable than not as tolerable as osimertinib, but whether people will just get osimertinib plus amivantamab. And AstraZeneca is very smart. They're running a trial in Asia, osimertinib plus amivantamab, to show the tolerability and all that. I don't think we have used it off-label in some cases where insurance will pay for it. So again, the magnitude of benefit and also very comparison. Andy will have a lot of things to say about the subgroup analysis. We are assuming this is positive. It could still be negative. They missed their interim analysis, so that's why there is a chance that it could be. Because of the rash, when patients have to get out of the study, it's censored for progression, so there is a potential for that anomaly in a clinical trial. I just throw this in because this was presented in ASCO this year. 789 essentially post EGFR TKI. randomized to chemo plus or minus IO. We already knew the, so this is keynote, so this is Pembro negative, FA final analysis. We know the previous trial, nivolumab was presented in ESMO Asia, so this is checkmate. It's very similar design, chemo plus or minus nivolumab, and the overall survival is also negative. So it wasn't a total surprise, it was expected, and so the paper is not out, it's not even published yet from ASCO as far as I know. But then there is Mariposa 2, which is the second line to try to, I think J&J is very smart. You know, in case the Mariposa fail, they have a second line to back it up. So this is very straightforward, chemo versus chemo plus lazertinib, amivantamab. I heard it was positive, but there was no press release yet. So they say it was very positive, but I haven't heard the press release, so we don't know. This is maybe rumor mongering. There is also a lot of people are saying that this is direct comparison. They forget to mention that there is actually a third arm, which is chemo plus amivantamab. So this could also be positive too. We don't know. We don't have to have a full drug combination. We could have a free drug combination. Again, this is a presentation in ESMO within 2 months, and also potentially a plenary session. So ESMO is already carved up like the whole abstracts already for the plenary sessions. Again, this may also be practice changing, because we will then have a bispecific antibody and a TKI together with chemo as the second line treatment. Although now we're already using chemo up front, so that's how the, you know, lung cancer is now the new lung cancer. We have no idea what's happening. We'll quote this. So this is wrong. I was wrong. That was last year's slide. So there is Enhertu or trastuzumab deruxtecan approved for HER2 mutated lung cancer. So it is an accelerated approval, but it is approved. So we finally will have an ADC in non-mutant non-driver mutation positive non-small cell lung cancer. So this is ADC versus docetaxel. So docetaxel is the 5-FU in colorectal cancer. So you better beat docetaxel, otherwise you're in trouble. The press release was from AstraZeneca again. It was actually a shock because it was possible co-primary endpoint. The co-primary was PFS. It was still not mature for OS. So people are thinking, whoa, you can't even have overall survival versus docetaxel. It doesn't take that long to beat overall survival. It's about 8 or 9 months. So we don't know. So that's also going into ESMO. So co-primary endpoint is PFS and OS. They are positive for PFS. OS is immature from the press release, so that's going to be a challenge. We anticipate it will be approved together AstraZeneca and Daiichi. This is a co-licensed compound. Again, we don't know about the TROP2 expression in breast cancer. That doesn't seem to be important, and there's no stratification by TROP2 levels, so that could be imbalanced. But the OS is not mature, which worries a lot of us, because people should be able to beat docetaxel with an overall survival benefit. Exon 20 is still a rare subgroup of EGFR mutated lung cancer, about 10%, very diverse mutations. The reason I mentioned that is there are 2 drugs that had accelerated approval. One is amivantamab, the J&J EGFR MET antibody, bispecific antibody. The other is the mobocertinib. Both have FDA accelerated approval. They are relatively similar in terms of the overall response rate. One is infusion, has its own side effects, rash and infusion reaction. Mobocertinib on its own has others such as diarrhea, which is a problem at 160 milligram once daily. 2 pivotal trials has been completed, and the results Exclaim-2 is very straightforward, mobocertinib versus chemotherapy first-line treatment. It is a negative trial. It was in the quarter report of Takeda, and people pick it up. The overall survival or the PFS curve overlap, I was told. I thought the pill may not be as good because of it's too big to penetrate the CNS, and it also has a lot of side effects. But it is an overlapping PFS curve, apparently. Papillon, on the other hand, is the J&J compound. It is a positive trial by press release. Chemo plus or minus amivantamab. So apparently this is also a pretty positive trial. It will go to ESMO. We don't know what it is, because it's an exon 20 subgroup analysis, subtype, so it may not be as popular to get into the plenary session. Again, the benefit, if Papillon is very positive in terms of improvement in a few months of overall PFS, then it will be the first-line indications, chemo plus amivantamab. It's a little bit, they have side effects, but it will be the standard of care. And then what will happen to mobocertinib when the pivotal trial failed? The accelerated approval may be pulled. It is not approved already in EU. They were not impressed with the overall survival, overall response rate. So Pacific, Andy will have a lot of things to say. Pacific 2 is basically, I just realized there's no Pacific 1. It's like the movie John Wick. There's John Wick 2, John Wick 3, but there's no John Wick 1. So Pacific 2 is chemo, RT, durvalumab, followed by 12 months of durvalumab versus placebo. We already know that Pacific is positive, as durvalumab was for 12 months, positive for PFS, positive overall survival. One of the few lung cancer trials that got New England Journal for PFS and OS, one of the few, but it's getting more popular. The proper design, I think, should be Pacific versus Pacific 2. So Pacific is chemo, RT, followed by durvalumab for 12 months. Pacific 2 should be chemo, RT, durvalumab. So you only get about 2 infusions of durvalumab. It's given once every 4 weeks. So within 8 weeks, you will have finished your chemo, RT, and then followed by durvalumab for 12 months. So tolerability, toxicity, and all that we'll have to see, and whether you will really add 2 more infusions of durvalumab during chemo RT. I guess it's possible, and we'll have to see the ILD rate and all that. So Pacific 2 will be presented in Singapore, so within under 4 weeks. And then finally, Alina, just to, this will be in ESMO. We expect it to be a positive trial. It has no press release yet. Very early stage, resected early stage, all positive non-small cell lung cancer, randomized to alectinib for 2 years versus 4 cycles of chemo. It's a little bit different design than Adura. Adura is you finish all the treatment you need and then followed by maintenance of osimertinib versus placebo of 3 years. A very similar design for the RET fusion positive lung cancer is also very similar, selpercatinib versus placebo. So these are all the trials that will potentially affect how we practice lung cancer, especially FLAURA2, Pacific 2, we're not sure. Papillon will at least consolidate how we treat exon 20 insertions. Mariposa 2 will be very interesting, to say the least, if it's positive, how we choose between FLAURA2 and Mariposa 2. And we see a lot of EGFR mutated lung cancer patients in Southern California. And then we'll finally have an ADC. You have to be very positive because ADC is expensive. And we'll see how they beat docetaxel. That's going to be a challenge. We're all expecting they should just blow docetaxel out of the water, but who knows? And the early stage lung cancer, we have more and more positive adjuvant trial, so we should screen for lung cancer in never smoker. That's
Like, share, and subscribe here on OncologyTube to get notifications when similar videos are available.